afternoon, everyone. We'll be starting innovations in practice and do-it-yourself session. I would like to invite Dr. Jagdeep M. Kakadia, sir, a very innovative person, as a chairperson for our session. We'll start from below. Nero Augustine will be presenting on indigenous do-it-yourself, hands-free smartphone mobile indirect ophthalmoscopy.
hands-free hands-free smartphone-based mobile indirect ophthalmoscope or HF SMIO. Smartphones have become the basic necessity in today's world, and in recent times, smartphones have been used for fundus imaging, especially in ROP screening. So, fundus imaging is of utmost importance, especially in ROP, especially in terms of documentation and training of new ROP specialists, assessment of regression and progression of ROP stages, for medical legal implications as well as parent education. These are the ideal ROP imaging devices available today, like Forest 3 Netra and RectCam. These have the drawbacks of having heavier probes, difficulty in portability, and for their exorbitant prices. Here we introduce our DIY hands-free smartphone-based indirect ophthalmoscope. I'll share a video depicting the assembly of the same.
Herewith we describe the making of the DIY HF SMIO, do-it-yourself hands-free smartphone mobile indirect ophthalmoscope assembly. Idea credit goes to Dr. Mahesh P. Shanmugam. It consists of 1. Headband of a discarded indirect ophthalmoscope. 2. A flexible arm of a flexible table lamp. 3. Universal mobile phone holder. 4. Counterbalance made with in-house material. First, the flexible arm is attached to the universal mobile phone holder using the discarded T-junction of the slit lamp attachment for the fixation light. There is an additional aluminium plate to support flexible arm assembly attachment to the head mount. Once it is assembled, then we can see that it can hold the mobile phone and the flexible arm can be bent accordingly. For attaching the counterbalance base plate, the soft padding on the back side of the head mount is opened and the screw is undone to open the back tightening knob. The screw holding the back tightening knob of the headband is secured. The knob functionality is reassessed by rotating the knob for tightening and loosening the headband. The counterbalance assembly is made in-house using a discarded plastic plate with some serrations. The cup is a discarded lens cover with a microscope with some counter-outward serrations. The weights are some random solid metal objects. The coupled weights are twisted onto each other as a counterbalance assembly. The reason for having the counterbalance is to avoid slippage of the head mount with the mobile phone weight, without which that the headband tends to slip and that can be exaggerated after movements of the holding assembly. The approximate weight is double the weight of mobile phone and the flexible arm. Herewith we
So here are few images that were captured by HF SMIO. In the first picture, we can see a zone 3 stage 2 disease with pre-plus. The second picture, we see a regressed popcorn lesion on the ridge, which is seen with active indentation. Here are successive images showing a ridge, stage 2 with a ridge in the first image. The second image shows the developing neovascularization on the ridge. The third image is immediately post-laser. And the fourth image shows regression of the ridge with the neovascularization after the laser, after 1 month. It is also important in training a new ROP specialist for screening, especially in terms of adequate indentation, as incorrect indentation can result in missing of findings in ROP. Here are serial images of a preemie who had poor pupillary dilatation with APROP. She received one injection of Avastin followed by ROP laser, and the serial images is showing resolution of plus disease in 4 weeks after the laser and injection. Here we show comparative images of ROP screening and setup of the instrument of HS Mayo as well as Forest Trinetra. Here is the picture of the specialist with carrying 3 bulky bags carrying Forest Trinetra. Here we see the specialist setting up the Trinetra device and the laptop showing time for setup on the side. And we can see it takes about 3 minutes 45 seconds for the complete assembly. Here is the specialist with the HS Mayo, and here is the assembly with HS Mayo, and the laptop showing the time of about 43 seconds only. Hence the advantages are we can do simultaneous indentation and recording of peripheral images. There is scope of extra maneuverability in the instrument. It provides better control and is cost effective and easy to set up. The disadvantages are there are few quadrants which can be difficult to indent and image during the instrument. It requires good pupillary dilatation, good IDO skills, and it's not wide field and requires multiple field images. It may show a higher indent and can result in missed findings, especially in a novice specialist. We conducted 2 observational studies using this new device. In the first study, we captured fundus images of preterm babies from 5 NICU referral hospitals over 6 months. These images were captured using iPhone 5s by a single retina specialist, and 175 snapshots were assessed. And all the most of the snapshots had good quality image as recorded by a standard image quality assessment scale in terms of noise pixelation, sharpness, contrast, artifacts and reflexes, and diagnostic confidence percentage. The second observational study, which was done over 3 years using iPhone 5s and iPhone 7, which were taken by more than one consultant. We assessed 349 snapshots of which were taken from video clips captured by HF Mayo, and these were assessed by 2 observers individually in a blinded manner using the same scale. And we had good quality images from this study as well, and it provided accuracy in diagnosis as high as 89.39%, and there was good overall match between the reviewers in terms of all quality images. To conclude, the images acquired with the help of HS Mayo are of good quality with minimal noise or pixelations and artifacts. It is a good alternative imaging device, especially in small setups for screening and teleconsultation. It is easy to assemble and use and proves to be a cost-effective solution in early diagnosis and assessment of progression of a universally important disease such as ROP. Thank you for your patient listening.
Thank you, Dr. Mero. It was a nice presentation. Most of the things what we have seen is handmade 3D printed mobile phone under camera.
Yes, sir.
It makes nice things.
Yes, sir.
Do a lot of things. So very nice.
Thank you, sir. Yes, sir. We are in the initial stages of it, sir.
Congratulations.
Thank you, sir.
It's a very nice idea. You get the images like this, or you have to crop?
We actually took screenshots of the videos that we acquired, sir, because the flash of the camera works only continuously in a video
when
mode.
it's video. So
Yes, sir.
that is used as a light source.
Yes, sir.
Right.
So from that we got the screenshots and then cropped it, sir.
Yeah.
is
But-
something that we are.
But the idea is
considering.
very good to keep the examiners both hands free, and that's the most important thing. Congratulations.
Thank you, sir. Thank you, everyone.
Now I would like to call Dr. Sudha to present Golf GoPro operations live on face. So meanwhile, Dr. Satish, commercialization, innovating is much more easier, what I feel, because we have started innovating, and doing commercialization is somewhat more difficult, because to get the licenses, to get all the passing of things. Okay. But medical devices. As a medical device, if we want to get.
I agree with you, Venkatesh, that if it's any device which is implantable temporarily or permanently, or if it is any therapeutic device, then you have to go through the entire rigorous activity of the FDA approval. But for the diagnostic equipments or for non-contact equipments, you just need a registration. It's not-
These all come under class A. Okay, and now actually I'm in the process of, we have invented a smart MNC XL, collagen cross-linking, which is a class B, low risk actually. That will need. So I'm in the process of like getting too much rigorous, like every electronic device has to pass through. So it has to pass through so many this thing, and getting a medical license is also quite difficult. It's not that easy. Innovating is much more easier, but to get license for mass production, because the cost is hardly meager. But once the licensing part we go into, it becomes too much difficult for the innovator or something. Fine, Dr. Sudha, please. Thank you, sir. Dr. Sudha.
Good afternoon to all of you. I'm here to talk about golf or GoPro operations live on Facebook. This is a brief overview of the surgical training regime that we follow in Arvind Eye Hospital, Pondicherry. So as with everywhere else, we start with wet lab practice, move on to simulation-based training, one-on-one training, and then step-up training or golf, about which I'll give some more details. This is followed by surgical recording of videos which are used for discussion in our meetings and in mentor-mentee partnerships. Theory before practicals. So we start with suggesting books to our surgical trainees which they read, and they have to take a test after that. Then they go in to know more about the machine, the foot pedal mechanics, the parameters. We don't have a simulator in Pondicherry. We send our surgical trainees to Madurai for a 1-week period to undergo simulator-based training. Wet lab practice using the human eye or the goat's eye. The first 25 surgeries that are performed are on a one-on-one training basis. The trainer stays with the trainee throughout the surgical procedure from the start to the finish and guide the trainee at every step. after the first 25 cases, we go on to what we call step-up surgery. Here, the surgeon is operating independently, but they are allowed to operate only on microscopes which have the GoPro camera attached to it. The GoPro camera relays the surgery live through Facebook, and the mentor or any other senior surgeon who is outside the OT in the OPD or elsewhere can supervise the surgery and guide them when they are in any kind of issue. So this is the novel e-mentoring and e-learning module. So what is so special about GoPro? It is commercially available. It's a very lightweight camera, and it is portable, it's compact, it's less than the size of our palm, and it can give you very high resolution images which can be recorded and live streamed. This video is just to give you an idea of the clarity of the images that the GoPro camera gives you. For use in ophthalmic surgery, the original GoPro is modified by the Backbone company. They add a C-mount lens to it, which increases the magnification and it reduces the field of vision. So what happens is the focus is only on the eye and not on the surrounding structures, and the image clarity is so much better. These are the different components that need to be fitted. First is the beam splitter. The beam splitter ensures that while one portion of the light goes through the eyepiece to the surgeon, the other portion goes into the camera adapter and onto the modified GoPro to be relayed. So the surgeon's point of view is exactly what is being recorded. So this is the whole assembly. And there's a GoPro app that can be downloaded on various Apple or iPhone devices. And it can be seen either on the iPad or on the mobile or on a PC. For live streaming, we need to use the Wi-Fi or a Bluetooth. It also has an inbuilt audio recording system on the camera. So this is the compact kit. The GoPro camera is then attached by a means of the adapter to the microscope and fixed there. The app is done, opened and synchronized with the GoPro phone. It can be used to instantly live stream to designated Facebook pages, and exclusive access is granted to a closed Facebook group. In the OT, the surgeon's point of view is recorded on the camera, and it's being relayed to a mentor outside who will then give his or her comments, and that will be recorded. It has to be read out by the assistant. So it can be used for online learning.
Guidance from the seniors. When a junior surgeon is operating, the live video streaming can be used to get guidance from the trainer or any senior surgeon. Junior surgeon can present their problems through the GoPro microphone, and the trainer can keep adding comments in the comment box, which can be conveyed to the operating surgeon by the assistant.
It can also be used for offline learning. So even if nobody is watching you while you're operating, you can always take it back and discuss.
Actually, what I see is now this cortex is very sticky and you're trying to forcefully aspirate it. You've done a good job, and this can cause sometimes a posterior capsular rupture. So the best thing is you do saline jetting there. Release that cortex from the capsule and then you aspirate it. Then you will find it much more safer.
So it can also be used for remote learning. The surgeon is one area, the mentor is very far away, maybe in the OPD or in the library or even having lunch. And in between patients also, we can view the screen and we can put in our comments. What is important is all the videos are archived in the Facebook page. So we can go back at any point of time and review it with our mentors. We have now made it mandatory for all our residents to maintain YouTube accounts. All the videos all the surgeries that they perform are downloaded, and there is a record on a digital record of all the surgeries. So apart from the regular logbook that they maintain, they also have these records. It can be used for small group discussions. We call it FaceBeam in Facebook. We can discuss regular surgery. Every Friday evening in Pondicherry, we conduct what we call performing successful cataract surgery meeting. These are regular review meetings where complications that happened in the previous week are reviewed. The surgeon who had the complication will present the case, and the audience is usually all the fellows, the PGs, and medical officers from the cataract and general units. And we try to understand where the problem might have happened and how it can be, how it could have been avoided. It is cost effective, much less expensive than the inbuilt digital recording systems. But we are hoping that in future it will be even better and less expensive. We depend on internet connectivity right now, and that is not good all the time, like we had the recent catastrophe yesterday. But otherwise, we are hoping that with technological advance, the connectivity should be better. Right now, the surgeon depends on the assistant to read out the comments. We are hoping that if we can include it in a smart TV, so we can read the comments of ourselves. So there are so many advantages to video recording. It's a good tool for critical self-assessment. It can be used to educate a large group. It can be used for documentation, research, and practice building. So these are the various stages in the development of a surgeon, from the beginner surgeon to the expert stage. So first is the stage of unconscious incompetence, where they don't even realize, or we don't even realize we made a mistake. And we have a PCR, then the assistant will tell you, madam, you've had a PCR, and then we're like, oh my God, how did she see with the naked eye what I couldn't see through the microscope? Next is the stage of conscious incompetence, where we realize that we made the mistake. Oh, the rhexis has run off. Oh, I made a premature. These kind of conscious incompetence. Next is the stage of conscious competence, where we are taking an extra effort to make sure that the step doesn't go wrong. Finally, where we all hope to achieve is the stage of unconscious competence, where we are working at a spinal reflex level. It's muscle memory, and we might be operating in the OT while our minds are thousands of miles away. And that is where we need to get. So in this stage of transition from beginner to expert, the critical stage is the stage of transition from conscious incompetence to conscious competence. And it is at this stage that guidance and mentorship play a critical role. And if we can identify what errors there are through our GoPro videos, through golf, through our discussions, through our mentor-mentee partnerships, this is the critical time where we can help the budding surgeon blossom into the most beautiful, high volume and highly skilled surgeon. So our attempt through golf is to help in the transition from stage 2 to stage 3. And golf is our attempt to give life to surgical training. Thank you.
Nice presentation, madam.
Thank you, sir.
One thing, GoPro 7 or GoPro 5, now it's quite difficult to get it. Now actually 12, 11, it's very common.
Okay,
and
sir.
I don't know how to probably disassemble them or
Ma'am, GoPro 7 is now no more available, and GoPro 9 onwards, they have made it almost impossible to change the lens. And I have spoiled 2 GoPros just trying to change the lens.
Sir,
So-
Aurolab is doing this. Okay. Okay. Okay, sir.
GoPro 7 is out of the market, but otherwise, this is a superb idea, and it's an excellent this thing. Maybe some other GoPro-like cameras.
probably the main part is the sensor what we capture for everything. If we can get the actual original manufacturer of the sensors, then automatically such modification can be much more easier actually. Their sensors are much more superior. We don't want that lens part because our attachment and everything will be there. Mainly that sensor what they have, if we can get somehow, that should work out. Nice presentation.
Thank you, sir. Thank you, sir.
Now I would like to call Dr. Satish Seth for his presentation. So you can club both the things.
Hello dear friends and colleagues, we are very happy to introduce to you Moxie Glow. While doing experiments with UV lights,
Good afternoon, everyone. At the outset, I wish to thank the Bangalore Ophthalmic Society for giving us the opportunity to be with you here and present the innovations that we have been carrying out over last 2 or 3 years. So this is a very, very important concept what Dr. Kakadia sir has developed. It was a fluke accident. So he was counting a lot of money in his practice, and by mistake, he happened to use a UV light, and a fluorescent moxifloxacin drops 500 fell on the 500 rupee notes. So suddenly the 500 rupee note started glowing. Then he said as to why this 500 rupee note is glowing. Because this UV light was there and 500 rupee note was glowing, he found out that this fluorescent, say moxifloxacin eye drop, contains a fluorine element. Fluorine element will flourish in a UV light. So that's how he had conceived the idea. So innovations always happen this way. And he's a very, very great innovator. I have got a lot of respect for him. And he should be awarded nothing short of, Padma Shri, Padma Bhushan, Padma Vibhushan. He deserves it. He deserves it. Yeah. Now we'll start the presentation. Yes.
hello dear friends and colleagues, we are very happy to introduce to you Moxie Glow. While doing experiments with UV lights, it was a serendipity finding for us that at 395 nanometer UVA purple light, moxifloxacin is a fluorescent molecule. Then digging deep in the literature, we realized that moxie is essentially a fluorinated derivative of quinine, and the word fluorescence is derived from fluorine. So the fluorescence of fluoroquinolone is thanks to fluorine. Based on these facts, we devised a device named Moxie Glow, which is fitted to surgical microscope and also to slit lamp. This Moxie Glow helped us to actually visualize the moxifloxacin in real time and also enable us to record what really happens to it in the anterior chamber. Molecular molar weight of water is 18 grams per mole, of mercury it is 200.5 grams per mole, of lead it is 207 grams per mole, whereas molar weight of moxifloxacin is 401.4 grams per mole. So at full concentration, the moxie is 22.3 times heavier than water and 2 times heavier than mercury and lead, and it is not readily miscible with aqueous humor. It is so heavy that even if we add it in BSS pint, it gravitates down. So when we inject undiluted 0.1 cc of 0.5% moxie, we can see that it remains localized, not readily miscible in the rest of the anterior chamber, and it will not be homogeneous, and some or much of it may leak from bigger side ports. So protection provided and the results will be variable. For few hours, the concentration here can be as high as 5000 micrograms per ml, which may cause endothelitis or iris atrophy. According to ESCRS endophthalmitis study and Irvine Group study, if you don't use intracameral moxie, there is a 1 in 1400 chance of endo, and if you use, the chance is 1 in 5800, so there is a 4-fold risk reduction. Erratic or low dose moxie, 1 in 3400 chance, and erratic high dose moxie, TAS and iris atrophy chance. So it is a Hamletian dilemma, like a ditch or dike, to use or not. So what is the solution? The solution is to make a solution, a diluted solution, which we have learned from Dr. Steve Arshinoff. The ideal concentration of moxie is 1500 micrograms per ml, and fill the full anterior chamber with it, to make which we add 1.5 ml moxie in 3.5 ml BSS, which we call moxie mix, which is 1500 micrograms per ml. We insert the moxie mix cannula from side port, always remaining in front of the iris, and inject the moxie mix whirling it and swirling it till the entire chamber is full and the moxie starts to overflow from this and the opposite side port, and then we hydrate the side ports with the same solution. We can see moxie going into the corneal stroma around the side ports, and then we check the intraocular pressure to be around 20-25, and this is the last step of the surgery. Even after this dilution, it still is identifiable because it looks very faintly pale yellow. But if still there is any confusion in the minds of doctor or staff, we can just switch on the Moxi Glow and we can instantly realize which syringe is containing diluted Moximixi and which one is containing the plain BSS. This video under Moxi Glow is taken 7 hours after the surgery, and we can still see that the moxifloxacin is present in the anterior chamber significantly. It's almost the same amount which we had injected at the end of the surgery. With acetazolamide 250 mg given immediate post-op, we can see moxifloxacin in a fairly significant amount even at the end of 10 hours post-op. Even after 15 hours, we can still see significant amount of moxifloxacin in the anterior chamber. Even after 24 hours, the tenacious moxi is still there. With Moxi Glow, we can use Moxi eye drops to stain the cornea instead of fluorescein sodium. Cataracts are also fluorescent due to beta-carbolin and tryptophan, so we can shine the Moxi Glow to detect or demonstrate the presence of cataract. This child had congenital nasolacrimal duct block in left eye. 20 minutes after putting Moxi eye drops, when we shine the Moxi Glow, we can see that the drug has passed into the nose on the patent side while the drug is retained in the lacrimal lake on the blocked side. This is good for us for confirmation as well as good for demo to parents. There are many other uses of Moxi Glow, but that we will discuss in future some other time when we have more time. You can buy this from Amazon and use as DIY Moxi Glow and have glorious, glowing and evergreen carrier with Moxi and Moxi Glow. Thank you very much for your kind attention.
Thank you for the patient hearing. So we have got one demo here. This is a UV light that we have, and this is, if you shine it through this, it will flourish and you get to see this greenish color there. So it is as simple as that. So better use moxifloxacin during your routine surgeries, but better dilute it, because the complications that we are anticipating these days of iris atrophy and TAS is because of the concentration of the moxifloxacin. So you make it a solution. So you have to have a solution to make it a solution. So that's how it's important. Thank you very much.
See, the general practice is to inject 0.1 cc directly into the anterior chamber, and it's not readily miscible, and it gravitates once the patient sits towards the lower half. That's why we get the iris atrophy in the lower half or endothelitis in the lower half, because cornea does not tolerate more than 2700 micrograms per ml, and the mean lethal concentration to kill MRSA, the methicillin resistant Staph aureus, is 1200 micrograms per ml. So Dr. Steve Arshinoff suggested to use 1500 micrograms, which is 1GEM2 safe and is above the MIC. And we realized that it stays in the anterior chamber for 24 hours. And at the end of the session, I'm going to put one Moxi drop here on your palm, and you will be able to see that it will be there even tomorrow morning, even after you have taken the bath. So tomorrow morning you all meet me and I'll shine the torch and you'll be able to see a trace of Moxi in your dermis cell. Shine the torch. See, it glows. And it does not go to the right hand. If I leave it for a minute or so and then wipe, it still stays. So not using Moxi is very risky, and using overdose of moxie is also risky. So we found the right way. Thank you.
Most of the surgeons nowadays we are using intracameral moxifloxacin. So that's why the endophthalmitis cases have come down very significantly, what I feel. And another interesting point about this thing is, sometime, especially in hard cataract, if you are doing phaco, there will be wound burn. And even after, sometime even with 2.2 or 2.8 mm, we have to sometime put sutures also to close the wound, because it doesn't hydrate and seal the wound. In those cases, actually on the table, sometimes we feel that the wound is sealed, but on the next day we find shallow ACs. So in those cases, intraoperatively, putting a moxifloxacin and checking for leakage will definitely help too, so that next day we can avoid patient being taken to OT. Nice one, sir.
Dr. Srinivas.
I would like to call Dr. Srinivas to present his 3D printed prism holder for Perkins tonometer.
I thank BYS for having given me the opportunity to present this project. We all have encountered breakage of the prism holder of Perkins tonometer. We have our good relationship with our trade partners, and anyway, they supply us very quickly. In spite of that, if we keep losing the prism holders very often, then it's a headache. So we use 3D printing to sort out this problem. I'll run the video.